Center on Budget and Policy Priorities. This webinar is essentially a follow-up on Edwin's great presentation at our annual Health Summit in March. So before I turn it over to Edwin, I just want to give a few notes to everybody on the technology of the webinar. So unless you're absolutely sure that you have a headset with a microphone that allows you to speak through your computer, in order to ask questions, you'll either need to call in or type in your questions. You can find the call-in number from your email, or while you're connected, you can go to the audio menu, select Use Telephone, and it'll provide you with a dial-in and access code and all that stuff. And remember to enter in the audio pin if you're doing that option. If you have any additional technical difficulties, you can call GoToWebinar at 1-800-263-6317. Or you can send me, Tara Robinson, a chat or a question. And just so you know, owing to feedback issues, we generally have everyone on mute from our end. When you'd like to ask a question, and there will be times when Edwin will welcome questions from everyone, you can select the hand icon located in the control panel. It's a little small column to the left of your menu. It's a little hand with an arrow. So if you click that, we know you want to be unmuted and you have a comment or a question. And if you have any trouble being heard at any time, you can always type in a question and we'll read it aloud. And one question that everyone always asks is, will we get a copy of the PowerPoint? Yes, we will be sending out a copy of the PowerPoint, and we will post the video of this on our website so anybody can watch it later. Okay, so with that, I'm going to go ahead and turn it over to Edwin and welcome Edwin. Thank you so much for being here.
Thanks, Tara, and thanks to Family Voices and having the opportunity to present today. So I'll talk today about how the recently enacted health reform law will affect California's children and youth with special health care needs. So first I'll go through some of the immediate provisions that are going to take effect this year, principally in the fall. Some of the major changes to Medicaid and the Children's Health Insurance Program that will take effect in 2014. And then finally, some of the additional provisions related to new health insurance exchanges for those who, without access to employer-sponsored insurance, have to purchase coverage in the individual market or have coverage through small businesses, and the tax credits that are available to purchase coverage. So first, let's get to an overview of the health reform law. So it would significantly expand coverage. According to the Congressional Budget Office, which is Congress's official body to estimate the effects of spending and revenues and coverage of various provisions, they estimate that the health reform law enacted in March will reduce the number of uninsured by 32 million people by 2019, relative to what would have been the case under the law prior to enactment of health reform. That means about 92% of the population would have health insurance, 94% of legal residents. It's the greatest health coverage gains since the Great Society 45 years ago with the enactment of the Medicare program and the Medicaid program. According to various analysts, for example, the Urban Institute estimates that nearly 4 million of California's uninsured become newly eligible for coverage under health reform. Another 1.5 million are already eligible for public programs like Medicaid. The UC Berkeley Labor Center has similar estimates. Again, a little over 4 million of the uninsured will become eligible and potentially be able to gain coverage. Now, what are some of the key coverage provisions affecting children and youth with special health care needs? There's new requirements, particularly important during the budget crisis here in California, that the state cannot scale back Medicaid and CHIP eligibility requirements. There's new market reforms and consumer protections being provided for those with private insurance. And by 2014, there's going to be a series of major coverage expansions. Expansion of the Medicaid program, an extension of the CHIP program, additional market reforms, including not being able to charge higher premiums for those in poor health. As I mentioned, the establishment of the new health insurance exchanges, as well as tax credits to small employers to offer coverage. And they're the ones least able to offer coverage today, There's some smaller, more modest credits that are already available this tax year, and there'll be greater credits once we get around to 2014. So let's get to some of those immediate reforms and Medicaid and CHIP provisions. So the first, I think, probably the most important is health reform includes a maintenance of effort requirement. This is similar to what was included in the economic stimulus legislation from 2009. But states under health reform cannot scale back Medicaid or CHIP eligibility for any population. They can't make enrollment procedures more restrictive. That is, they can't make it harder to apply for coverage. They can't make it harder in terms of paperwork or other procedures to stay on the program. And this is true for children all the way through September 30th, 2019. And this is also true for adults, but only through December 31st, 2013. It looks at what was in place on the date of enactment of health reform, March 23rd to 2010. In other words, whatever the state's eligibility levels in place on March, California can't scale back eligibility from that level. Now, there is a few exceptions. There's an exception for states whose CHIP programs run out of federal CHIP funding. If there's not enough federal CHIP funding, states can scale back. Those we get to later on. There should be more than enough money for states like California to maintain their CHIP programs, the Healthy Families Program here in California. There's an exception for states being able to cut back eligibility for adults during a budget crisis who are already covered over 133% of poverty, but only a handful of states do that today. The next set of provisions are related to changes to the private health insurance market. And these are new consumer protections and options that aren't available today. One of the key things that many parents with children with special health care needs have found is their children age out. If they're in their parents' coverage, once they turn 18, sometimes 21, they're no longer eligible to participate in their employer's coverage. One of the immediate so-called market reforms that health reform includes is a requirement that all insurers offering a plan through both employers and in the individual market must offer dependent coverage through age 26. That is, children can stay on their parents' health insurance plan up to age 26. This applies to individual market plans, small group plans, large employer plans, and including the very large self-insured plans that a lot of employers offer. Now, this only applies to plans that offer dependent coverage. In other words, if a plan doesn't already cover families, they don't already cover dependent children, there's no requirement that they add family coverage. But if they already offer family coverage, then insurers have to offer dependent coverage for younger adult children. If an employer plan is grandfathered, that is a plan that is nearly identical to a plan that was already in place as of March 2010 when health reform was enacted, there's a restriction. If it's an employer plan and it meets grandfathered, the adult child must not have access to employer-sponsored coverage of their own. That is, they have a job that they're not able to get coverage through their employer. If added to plan, the insurers can't charge a special premium because it's an adult child. They can only charge a higher premium, the same higher premium they would have charged for any other dependent child being added to a plan. It takes effect the start of the first plan year after September 23rd of this year, which in most cases is January 1st, 2011. According to the Department of Health and Human Services, it's expected to cover roughly 1.25 million young adults with only a slight effect on premiums. Premiums will be somewhat higher. Another key reform to the private health insurance market relates to no longer being able to deny children for pre-existing conditions. Insurers can no longer deny an offer of coverage to children with pre-existing conditions. They can no longer deny coverage of a particular pre-existing condition once they're enrolled in a health insurance plan. Again, this likely takes effect at the beginning of next year. It applies to all plans except individual market plans that are grandfathered. That is, they're plans that haven't made any substantial changes to their benefits in coming years, and so it's very similar to the plan that was in place as of March. Plans may charge higher premiums, though the California legislature is currently considering a bill that would implement this protection, and it would limit how much insurers could charge in terms of higher premiums for adding a child with a pre-existing condition. One other thing that you may have heard of in press reports, and there's been a lot of policy focus on it, is there's $5 billion included in health reform to help states finance coverage for people who are so-called medically uninsurable, people who've been denied coverage because of their health status or pre-existing conditions. An individual must be uninsured for at least 6 months, denied coverage because of a pre-existing condition. So, for example, a young adult who's been denied coverage because of pre-existing condition, they're uninsured for at least 6 months, can participate. California has elected to operate its own pool. The federal government is operating pools in states that don't want to do their own pool. This will be run by the Mr. Mib agency here in California. According to Mr. Mib, they'll start accepting applications in August and begin providing coverage in September. So a lot of the issues in terms of what the benefits are going to look like, what the cost sharing, what the premiums, all that I think is still in flux and probably won't be known for at least a few more weeks. One additional protection is that there are a number of plans today that still have lifetime or annual dollar limits. That is, over the course of a person's life, as long as they're enrolled in that plan, their total benefits are limited to some specific dollar amount. Now, the dollar amounts can be $1 million, $2 million, but for a child, a young adult with pre-existing conditions, disabilities, chronic illnesses, serious conditions, cancer, and things like that, those $1 million annual limits can be breached relatively quickly. Again, first plan year, and this applies to all plans, after September 23rd, 2010, there can be no longer any lifetime dollar limits. This applies to nearly all plans. You cannot have a restrictive annual dollar limit, which is defined as $750,000, rising each year to $2 million by 2012, which would be for 2013's plan years. Certain plans can ask for waivers if they believe that this restriction on annual dollar limits will cause a reduction in benefits or increase in premiums. There are some plans now in the market today called mini medical plans that are pretty restrictive. You can't have more than $50,000 in benefits and things like that. There was some concern that these plans might be eliminated very quickly if they couldn't seek a waiver. There's going to be no annual dollar limits at all starting in 2014. This applies to all plans except those plans in the individual market that are grandfathered. As I get to the next slide, people can start thinking about Q&As. After I finish presenting this slide, we'll stop for a little bit to see if people have questions about the maintenance of effort and some of these private market reforms. So some other immediate reforms affecting children and youth, all plans except grandfather plans are required to provide preventive services without cost sharing. In other words, physicals, immunizations, no longer can charge a copay for. For children, these preventive services will include all the so-called Bright Futures, well child visits and screenings. Bright Futures is a new federal set of preventive screenings recommended for children. There's going to be a prohibition on so-called rescissions. That's where insurers, and this has been a big deal in California, Health Net, Blue Cross, Blue Shield, have been terminating health insurance enrollment in individual market plans for relatively minor discrepancies, mistakes, omissions on applications once people get sick and need a lot of health care. And they've been claiming that because of those omissions or mistakes, that was a reason to terminate the entire plan, and people have been left with hundreds of thousands of dollars in unpaid medical bills. There's been a lot of litigation and regulatory action about it. But now There will be no more rescissions permitted except for outright fraud or intentional misrepresentations. Lastly, Healthy Families programs, CHIP programs across the country weren't allowed to enroll children of state employees. Now, if children of state employees are unable to afford coverage through the state employee plan, they'd be eligible for CHIP in coming years. So with that, I will stop and see if there's any questions about what I've presented on so far.
Okay, so now's the time to raise your hand if you have a question to ask. Raise your virtual hand. And I see one question from Lori. Lori, I'm going to go ahead and unmute you so you can ask it. Lori, are you there? Lori, you there? Hi.
Hello,
Hi. Yes, now we can hear you.
okay, that's freaky. Okay, can you just please explain again the term grandfather?
Sure. You remember one of the principles both during President Obama's election campaign as well as during the health reform debate is allowing people to keep what they have. So a lot of these reforms may not apply to grandfathered plans. And the idea, you don't want to force people to change their plans, which might raise premiums somewhat by adding these new consumer protections and benefits. And so grandfathered plans are protected against some of these against some of these reforms applying to them. Now, the federal government recently issued interim final regulations on what grandfathering means. And basically what they're saying is if a plan is grandfathered, it has to be the plan that's basically the same plan that was in place when health reform was enacted in March. But if they make any major changes, including eliminating benefits for a particular medical condition, for example, if the insurer eliminates coverage of treatments related to cystic fibrosis, that's no longer a grandfathered plan. If they increase how much you have to pay in cost sharing, so it used to be 20% for surgeries, now it's 25%. The copay amounts, the deductibles are rising much faster than inflation, things like that. Employer is contributing much less to employees' costs, then they're no longer grandfathered. There's certain of the reforms that do apply to grandfather plans. That includes the extended coverage to dependents up to age 26 and the annual lifetime limits. Other things like the preventive services without cost sharing, those requirements would not apply to grandfather plans until such plans change, making some of those modifications I just sort of outlined.
Okay. The next question is from Victoria. I'm going to go ahead and try to unmute you, Victoria, so you can ask it personally. Let's see if we can hear you. Victoria, you there?
Yes, I'm here.
Hi. You want to go ahead and ask your question?
Yes, hi. I wondered if these new requirements are going to apply to private plans or just employer-offered plans.
It depends on the reform, but in general, they apply to both employer plans and individual market plans. If they're grandfathered plans, whether in the employer or individual market, certain of these reforms apply. Other reforms apply to all plans except for grandfathered individual plans. For example, the new restrictions on annual benefit limits, the new restrictions on coverage of children with pre-existing conditions so that insurers can no longer deny, that applies to all plans, including grandfathered employer plans, except for grandfathered plans purchased in the individual market. So any new individual plan will be subject to all of these requirements. If it's a grandfathered plan and it's classified as grandfathered on these new regulations that the federal government put out, depending on the particular reform and depending on whether it's employer-sponsored or individual market, will determine whether that reform applies or not.
Okay, thank you. And also, is it going to also apply to self-funded plans?
Yes, these requirements do apply to self-funded plans. Yeah, self-insured plans.
Self-insured, yes. Okay, thank you.
Great, thanks. So we have one last question typed in, so I'll read it out for Celia. She says, I currently have a case involving a young adult with sickle cell who's being dropped from his parents' employer-sponsored insurance because he's aging out at 21. I'm confused about how healthcare reform extension to age 26 will aid him. He's insured through Blue Cross.
So the child would be able to enroll in a grandfather, in their plan as a dependent starting in the next plan year. So in many cases, that's likely to be January 1, 2011. Some employers and some insurers are providing this benefit earlier. But if they are dropped over the course of the year, before the protection takes place, the insurer and or the employer has to ensure that there's a special enrollment period for that child to get back on once the protection takes effect.
Okay, thank you. So why don't we keep going, Edwin?
Sure. So let's go on to some of the big coverage provisions, the major coverage expansions that take place in 2014. Clearly, one of the most important provisions is a significant expansion of Medicaid. This is the largest expansion of Medicaid since the expansion to children below the poverty line and above under the Waxman provisions. Basically, January 1, 2014, all states have to expand their Medicaid programs to all non-elderly adults and children up to 133% of the federal poverty line, which is a little under $30,000 for a family of 4 under current poverty levels. More importantly, it also has no assets test. Many states still require an assets test for adults, so many have waived it for children. There is a caveat. The assets test is not being waived for eligibility for long-term services and supports, but for all other benefits, there would be no assets test. So this includes childless adults who've generally not been able to be covered under Medicaid, including youth who usually are limited to up to age 19. Some states have taken up 19 and 20-year-olds. This includes people with disabilities. So people with disabilities who have too high incomes to qualify for SSI. They would also be eligible for this Medicaid expansion. States have the option to start covering these populations at regular Medicaid match starting this year. This does mean that some children who are now on Healthy Families will be switched to Medi-Cal and gain EPSTT benefits, which could be vital for children with special health care needs. Now, the federal government is going to pick up the overwhelming proportion of the cost of this expansion, almost 100%, it's 96% over the next 10 years under our estimates. That's because the federal Medicaid matching rate, which is normally 50% in California, will be 100% for everyone made newly eligible who's enrolled for the first 3 years, 2014, 2015, and 2016. As you can see from the slide, it will phase down somewhat, but it will always be at least 90%. So the federal government is picking up 9 out of every 10 cents, 90 cents of every dollar of cost. The state, California, has to only pick up 10% of the cost. Regular match for current eligibles and newly enrolled. For those kids switching from CHIP to Medicaid, they'll likely be able to get at least the CHIP matching rate. One important feature, though, is despite the expansion, and in part for ideological reasons, in part because of cost, states are required to provide so-called benchmark benefits to this newly eligible population rather than the regular Medicaid package. This primarily has to do with non-disabled adults, people with disabilities. Children will still get the full Medicaid package. Children will still get EPSDT, for example. But other adults who don't have a disability, even though they may have chronic illnesses or medical needs, states can scale back what they provide to the newly eligible population. Now, these benchmark benefits can be the regular Medicaid package if a state chooses, but they can be more akin to private insurance plans. And as we know, in many private insurance plans, they don't cover a lot of the services that really meet the needs of people with special health care needs. It's up to the state, so it's critical that the state offers full benefits package, particularly to vulnerable populations like children and youth with special health care needs. Now, for those with long-term service and support needs, there are a few new vital options, including health reform, to make it easier for families to care for those with long-term needs in the community rather than in an institutionalized setting in nursing homes. There was already an existing option for states to provide home and community-based services without seeking a waiver from the federal government. Only a handful of states have taken that up. Health reform expands the types of services, the type of long-term services and supports that are eligible to be covered under this option. States are no longer permitted to cap enrollment of the option or limit it to a specific geographic area. They can target it. There's a new, what's called a community first choice option to allow a state to provide home and community-based services to individuals up to 150% of poverty who meet the needs criteria of a particular state. So whatever California's standard is for need for long-term services and support, if someone meets that, the state can cover them up to 150% of the poverty line. The federal government's encouraging states to take up this option by giving states an extra 6 percentage points in their Medicaid matching rates. Instead of 50% in California, it would be 56%. Now, there's some money also to so-called rebalance, to shift how much of your long-term care dollars are going to home and community-based services rather than in institutionalized setting like nursing homes. But California already meets that threshold according to one study. I'm not sure what California's official numbers indicate. So the state may be eligible for this. There's an extension of the Money Follows the Person demonstration project to allow people to have greater control of their long-term service and support spending. It also eased eligibility for that. California is one of the states that's currently participating in the demo, though I'm not familiar with how many people are currently enrolled in California's demo. One other Medicaid provision that's important related to coverage is for those youth who've formerly been in foster care. They tend to have greater medical needs and other social service needs. But once they've aged out, that population is at risk and often goes without coverage. There's a new requirement starting 2014 that all states must provide Medicaid coverage to youth who are formerly in foster care. It's through age 26, so 25-year-olds would be required to be covered. The condition is they must have been in foster care when they were emancipated, and they had to have been enrolled in Medicaid when they were emancipated. Now, one thing that it will be of interest is, and this is for those who help families get eligibility, get enrolled when they're eligible, help them through the application process, the renewal process, is there's a pretty major change in how income is going to be counted. There's a myriad of complex rules about what income is counted for purposes of determining eligibility under the Medi-Cal program here in California. Starting in 2014, states are going to have to change how they count income so that's more aligned with how the federal income tax system works. The idea is that those same income tax rules are going to be used to determine eligibility for the new tax credits to get coverage to the private health insurance exchanges. So by aligning it, it'll be easier to coordinate between the Medicaid program and the exchanges. This is going to be a lot of work figuring out because there's going to be certain income that's now going to be counted. There's going to be certain income that hasn't traditionally been counted that might be counted. There's rules that are going to be different in terms of who you count in terms of the household. But there's a lot to work through and to ensure that there's appropriate coordination with the exchange. One thing of note, states already have the option to make people presumptively eligible, particularly children and pregnant women. That will be extended to the newly eligible population. So if someone comes into a hospital, a community health center, they could be made presumptively eligible, and then the state will determine eligibility after the fact. But it allows people to get the services they need right away. So it's an important option. To help ensure that there's sufficient physician access, there's a good provision. Certainly the provision could be improved and extended, but it requires states to increase primary care physician rates to 100% of the Medicare rates in 2013 and 2014. Federal government is going to pick up 100% of those costs. However, again, it's only 2013 and 2014, so states can reduce rates afterwards. The original House Health Reform Bill had a permanent requirement with federal funding to stay at Medicare rates, but that dropped out due to cost. But this certainly could soften the blow. We know that there's a primary care shortage throughout the healthcare system, and this would ensure that the people newly eligible for Medicaid are able to get the primary care that they need. Lastly, before we take our next round of questions and answers, is that the health reform law, it didn't get a lot of attention, actually extended the CHIP program. So in 2009, one of the first pieces of legislation signed by President Obama was the CHIPRA legislation, which reauthorized the CHIP program, which funds healthy families here in California. It extended it through the end of fiscal year 2013. Health reform extends CHIP another 2 years through 2015 and provides $40 billion in funding over those 2 years. If you combine both CHIPRA and what health reform does, that should be more than enough money to allow California and other states to maintain and expand their CHIP programs. That is, if there's sufficient state dollars because of the budget problems California is facing. As noted, there's a maintenance of effort requirement. States can't scale back their CHIP programs through 2019. CHIP is going to require to use the same income tax-like income counting rules that is required for Medicaid. Finally, there's a requirement in health reform that the Secretary of Health and Human Services is to look at CHIP, look at what plans are being offered through the new health insurance exchanges, and send this study to Congress by 2015. I think the idea being Congress is going to have to reconsider reauthorizing CHIP in 2015 so that it could be extended beyond 2016, and how it will interact with the exchange and other elements of health reform could be revisited to determine whether CHIP should move forward in its current form with enough funding, potentially modified CHIP, potentially CHIP children being phased into the exchange. But certainly that would be something of intense interest for all of us as we get closer to 2015. So with that, I will stop again for another round of Q&A about the Medicaid and CHIP provisions.
Okay, well, other folks are thinking of questions. You can go ahead and use your raise the hand function, or you can type in a question. I have a few questions already. One is, when you were talking about benchmarks, Edwin, somebody wanted to know what the benchmark was for California and how they can find out.
Sure. The state hasn't decided this yet. This is clearly something where the federal government hasn't even issued regulations yet about what the benchmark would be. But in general, the benchmark would be similar to the standards used under the CHIP program, which is it can be a plan that is the same or equivalent to the plan offered by the largest HMO in the state, the Blue Cross Blue Shield plan that's offered to federal employees that all states' Blue Cross plans offer, or the state employees plan. But that's sort of a minimum level, and then the full Medicaid package would be the maximum, and a state could pick anything in between. And so we've done a lot of work showing that the newly eligible population, a lot of them are adults without kids. They tend to be in poorer health than even parents. They tend to be in poorer health than adults without kids who are higher income, above the poverty line. They have a much higher incidence of physical and mental health issues among those who are uninsured, and certainly there will be a lot of work needed to demonstrate to state policymakers that a fuller Medicaid package, something like the regular package, should be provided to the newly eligible group.
Okay, great, thanks. So other folks, go ahead and raise your hand or type in a question. I'm going to try to unmute Yvette. Yvette, are you there? Can we hear you? Yvette? Okay, I don't think she can talk. So her question is, for the extension to age 26 for foster care, do you know if this includes children who have Medicaid through AAP, Adoption Assistance Program?
I want to say yes, but I'm not totally sure about that. But I think the way the foster care provision works, that would include that, but I'm not totally sure about that.
Okay.
But I will try to track that down, then I can email Tara, who can get back to you.
Okay, great. That would be great. Thanks. Any other questions for right now on the last section? Give you another moment. Okay, not seeing any, so why don't we keep going?
Okay, sure. So the last section is about some of the insurance market reforms that take effect in 2014, as well as the new health insurance exchanges. So one of the key changes that takes effect in 2014 is that finally insurers can no longer deny coverage to anyone based on a pre-existing health condition. So now, instead of just children, it will be any adult. Insurers can no longer vary premiums based on health status or pre-existing medical conditions. They can't charge 3, 5. In some states, it's unlimited in terms of how much more they can charge someone based on their health status, that they have a chronic illness, they have some other pre-existing medical condition. They can't charge more based on their claims history, looking at what they've actually experienced in terms of what they used in health care, and then the next year charge them accordingly a much higher premium. Age would still be a factor, but now only 3 to 1. That is, you can only charge someone who's older 3 times what you would charge someone who's younger. Tobacco use can continue to be considered at 1.5 to 1. That is, you can charge someone who smokes 1.5 times what someone who doesn't smoke. Other factors that have been used both in the individual market and in the small group market, like gender, industry, geography, will no longer be permitted. In some cases, what job you have can affect the premium. And all these provisions would apply to the individual market and to the small business market. The large group markets already don't have these kind of premium rating rules. In addition, in the individual and small group market, for the first time, all plans are going to have to provide a minimum benefits package, what's called the essential benefits package. This is something that will be defined by the Secretary of Health and Human Services and Regulation. But what those services will have to include at least certain services that are outlined in the health reform law itself, ambulatory services, maternity and newborn care, hospital care, drugs, pediatric services, and the like. The idea is that it be comparable to the scope of services provided in a typical employer plan today, which would be much more comprehensive than a lot of the plans that are offered in the individual market currently. One thing is that pediatric benefits in the essential benefits package would include vision and dental, something that a lot of children's coverage doesn't include today in the private market. In addition, all plans will have to have a maximum out-of-pocket limit on in-network care. There are a number of plans that today in the market that may have no maximum out-of-pocket cap, or out-of-pocket caps that are very high, tens of thousands of dollars. So even though someone may be insured, they end up underinsured when they have a family member come down with a serious condition that requires significant treatment that's costly. They can still face bankruptcy, medical debt issues, even though they had insurance. It would be equal to the levels currently required under so-called health savings accounts, which are currently a little under $6,000 for individuals and $12,000 for families. But obviously that will be indexed upwards as we get closer to 2014. One additional, another key coverage component besides the Medicaid is the new health insurance exchanges. As a lot of us have experienced, when you switch jobs, you're going to a job that doesn't have employer-sponsored insurance, you have to go out into the individual market. Small businesses tend not to do very well compared to large employers because they can't negotiate as good a deal with insurers. They're charged a lot more. They have higher administrative costs that they have to pay for. there's going to be new health insurance pools called exchanges that all states will have to set up by 2014. If states don't show that they're making progress towards setting it up, or they opt out entirely, the federal government will step in and operate an exchange directly. Basically, the federal government will look at where states are at the beginning of 2013 and say, okay, this state has made progress, this state has not. We're going to make arrangements to have an exchange up and running in that state. Now, what's critical here is that for people purchasing coverage in the exchange on an individual basis, there will be a new federal tax credit to allow people to purchase exchange plans. Generally, it's for those between 133% of poverty, in other words, above the new Medicaid expansion level, and below 400% of the poverty line. Will be able to get some amount of tax credits to buy coverage. Legal immigrants who are currently subject to a 5-year bar unless the state waives it for kids and pregnant women would be also able to participate in the exchange and get a tax credit. This is just about legal immigrants. Undocumented immigrants aren't able to purchase through the exchange at all and would not be eligible for the tax credits. What would be the amount of the tax credits? Well, I put this chart together that's basically what would be the requirement in terms of families' share of the cost if the subsidies, the tax credits were available this year. So basically, at about 133% of poverty, a family would have to pay an amount equal to 3% of their income to participate in the exchange, but the federal government, through the tax credit, would pick up the rest. That would be, a little under $900 a year in terms of the annual premium. Now, at just under 400% of poverty, the family would have to pay 9.5% of their income for family coverage, which would be a pretty sizable annual premium of a little over $8,300. But that gives you the range of the subsidies that are available. In addition, this is pretty critical and doesn't get as much attention as the premium tax credits, is that for those below 250% of poverty, they're going to get additional tax credits that are going to basically buy up the coverage that's available through the exchange. And what does that mean? Well, everyone who gets a premium credit to buy coverage in the exchange will be given a subsidy that's large enough to purchase a plan with an actual value of 70%. What is actual value? It's a measure used by actuaries to compare the relative value of benefits. The greater the benefits, the lower the cost sharing, the higher the actuarial value. So basically, Medicaid, since it has very little cost sharing and very comprehensive benefits, it's closer to 100%. A high deductible plan in the individual market, maybe something like 60% or 65%, something like that, or even lower, depending on how large the deductibles are and the cost sharing. Typical employer plans are 70, 80%, depending on the relative generosity. But those with incomes below 2.5 times the poverty line get higher actual values. And so if you're below 150% of poverty, you're getting something closer to the Medicaid actual value, 94%. Those between 200 and 250 get 73%. Everyone below 400% of poverty also gets lower maximum out-of-pocket caps. I mentioned that the Essential Benefits Package has an upper limit on out-of-pocket costs. They'll be lower if you have incomes below 400%, you're subsidy eligible, and you're getting coverage through the exchange. Finally, there's tax credits to small employers to offer coverage. If you look at where young adults are who are the most likely to be uninsured, they disproportionately work for small employers. Small employers are also the ones least likely to offer coverage, particularly those of the small size in terms of the number of employees, and those with the lowest average wages. In other words, very small firms, oftentimes in the service industry, the average wages for their workers is relatively low. They're the ones least likely to offer coverage today. Employers now would be able to get a tax credit starting this year to offer coverage to workers. There's some requirements. The employer must contribute at least half the cost of the premium. The full credit is targeted to those firms I mentioned, those with 10 or few workers and average wages of $25,000 or less. The credit is relatively small, 35% between 2010 and 2013. It goes up to 50% and beyond, and for coverage through the exchange. It also goes to nonprofits. Nonprofit small firms are also just as likely as for-profit, and there's a credit for them for the first time. And tends to be the case that credits to employers, a lot of nonprofits can't qualify for because they don't pay corporate taxes. This should modestly increase the ability to offer coverage. You combine it with the new exchange, which allows small employers to offer coverage. This should improve the availability of employer-sponsored insurance among small employers, which tend to employ lower-wage workers. They employ a lot of young adults as well, and that's why they're more likely to be uninsured. So the key provisions in 2014, Medicaid, insurance market reforms, and the new exchange with tax credits for individuals to purchase coverage through the exchange, as well as small employers to purchase coverage through the exchange. So this is my last slide. I'll stop here, and then I'll take a Q&A on this section as well as on the whole presentation.
Okay, so for anybody who wants to ask questions, please go ahead and raise your hand. This is a great opportunity to talk to Edwin while we've got him here. I have a few questions that have already come in. One was, do you know if can private insurers raise premiums?
So private insurers can raise premiums. There is a new, there's several new requirements. So in terms of immediate effects, the federal government is sending money to states to help them develop rate review processes. Right now, and we've seen this in California with Anthem Blue Cross, they wanted to charge anywhere between 40 to 70% higher premiums for people in the individual market. They always have to, only a handful of states require insurers to submit data supporting those rate increases. And even when they do require it, sometimes states don't have the expertise, the infrastructure to actually look at that data to see if the rates are actually justified. Here, the state of California commissioned actuaries to look at it, and most of those rates weren't justified, and they've come down to 19%, and I think there's still a look at the review. So states are going to be given new rate review authority and some financial assistance. Once 2014 comes around, state exchanges will be required to look at rates by insurers participating in the exchange to make sure they're justified, that they're justifiable increases. Exchanges also can negotiate on behalf of exchange participants to try to get a better deal. But clearly, one of the difficulties is there's right now in many states not a very rigorous rate review process. So when insurers submit they want to increase their rates by X percent, sometimes there's little assurance that those rates are justified in any way. In addition, oftentimes they provide notice to individual employees. One of the reasons that the rates came up in California and were subject to so much scrutiny was there's a California requirement that insurers have to submit to beneficiaries what their rates are going to be in terms of the increase, and that allowed a tripwire to be triggered to allow the state to look at those rates. But that certainly is going to be one of the key things, because what a lot of insurers may do is they may say, these new requirements on market reforms, I have to cover dependents, I have to cover preventive care without cost sharing. That's why I'm raising the premiums. And it may be for a whole host of other reasons, including higher administrative costs, other inefficiencies, profit, and the like. And being able to tease that out and getting the state to ensure that it's scrutinizing rates carefully is certainly a high priority in coming years.
Great, thank you. I have a question from Anne. Anne, I'm going to see if I can unmute you. Anne, can we hear you? Anne? I don't think we can hear her. Okay, so I'll read it out. Anne says, can you expand on the credit of 25% and 35% respectively for nonprofits?
Sure. As I mentioned, a lot of the credits that employers can get now for a variety of things, they're not available for nonprofits because they don't pay corporate taxes. They wanted to make sure that just because you're a nonprofit, you're still encouraged to offer coverage. So nonprofit small employers who otherwise have, meet the requirements of contributing at least 50%, 10 or fewer, average wages below $25,000, they're going to get a credit against their payroll taxes, because nonprofits always have to pay payroll taxes just like any other employer for their own employees. So they're going to get a credit equal to 25% of what the employer is going to contribute to their workers' premiums, starting in 2010 through 2013, and then once we get to 2014, as long as they're purchasing coverage through the new exchange, they're going to get a credit equal to 35% of the cost of how much they're contributing. So if they're contributing $8,000 towards their workers' premium, they'll get a credit equal to 35% of that $8,000.
Okay, great. Another question that came in is, does healthcare reform help to provide dental coverage for a youth who is 20? My son has autism and Medi-Cal doesn't cover dental. Do you know if this will help?
So the requirement that the essential benefits package covers dental does not cover young adults. Now, there's a possibility the essential benefits package could include that. There's also a requirement that in the exchange, there be plans that offer dental-only coverage so that it will be more available. A lot of people can't purchase it now. It's not affordable. But I think there's still an issue related to access to dental care, particularly for young adults and adults in general. There's going to be a requirement for kids, but not for young adults in the essential benefits package.
Okay, great. Lori, I'm going to unmute you. Lori, you want to ask your question?
An agency has not offered insurance to their part-time employees. They can continue that policy?
I couldn't hear that. Could you repeat the question?
Okay. If the agency does not offer insurance to part-time employees, does that policy need to change? Do they need to offer part-time employees?
They do not need to offer to part-time employees, but there's what's called the free rider requirement, that if an employer does not offer coverage and the employee goes out into the exchange and gets a tax credit to purchase coverage, there'll be a penalty on employers. And there's some, depends on the definition of part-time workers, which will be fleshed out, but that'll create some financial penalty to get employers to offer to part-time. But there's no requirement that employers offer coverage to full-time or part-time. There's only a penalty.
Okay. We have time for another question or two, so if you still have a question, go ahead and type it in. I have one for you, Edwin. Do you know, are there any known gaps in coverage that healthcare reform, didn't address that were sort of unintended? And if so, are there any initiatives to fix that?
Sure. I think probably if you look at what the Congressional Budget Office said, when it says, there's a reduction of $32 million, but there's still going to be all these millions of uninsured left who will not be covered under health reform. And they basically fall into three pots. One is our undocumented immigrants who won't be allowed to purchase an exchange, that, as under current law, wouldn't be able to get Medicaid. Low-income people, this includes both children and adults who would be eligible either under current rules or eligible under the expansion in Medicaid but remain uninsured. It's the same issue we've had. There are a lot of people who are eligible. We've made a lot of progress, particularly with kids, but we don't have 100% participation. Now, no means-tested program like Medicaid is ever going to get up to 100% participation, but we need to get much higher than we are now. CBO assumed, as we've heard, that at least initially only about 50% of the adults who become newly eligible are going to participate. So that's still out there. There's some incentives to improve enrollment and coordinate enrollment, but there's a lot of work that needs to be done to get that population enrolled, and that's still definitely a risk. And the last population are those who may have access to coverage through the exchange or through the employer, but they remain uninsured. They may be subject to the individual requirement to have coverage, but they'd rather pay the penalty. And I think one of the things as we move forward on health reform is, can we make sure that the premium credits, the cost-sharing subsidies that I outlined in the exchange are more generous over time, so that you have more people participating. They may either be deciding they'd rather pay the penalty, or there's an exemption if coverage isn't affordable enough for you. And if you get everyone into the health insurance pool together, that makes everyone's health better. It also makes everyone's premiums lower if everyone's pooled together. And I think those are the three gaps that are out there. And I think in terms of bigger pictures, there's some provisions related to long-term services and supports, but it doesn't, and I didn't even mention the Class Act, which is a federally organized long-term care insurance system that would be made available. Long-term care as sort of a big issue that's facing the country isn't addressed in a major way. There are important things, Class Act, these home and community-based services options, but health reform didn't tackle that issue head on.
Okay, great. And lastly, what are some of the best places to get up-to-date information on how healthcare reform is being implemented?
I think there's, in terms of government resources, there's a new health reform website that the federal government's putting out that includes their latest updates as well as some of the insurance options, a so-called web portal. And you can go to our website, cbpp.org. The Kaiser Family Foundation has a whole host of issue briefs and updates about what's going on in implementation. And then certainly what's going on here internally. I know Health Access and others are working on and tracking some of the bills that are going through the legislature today that try to implement at least some of the immediate reforms and set the stages for planning for the exchanges and the Medicaid expansion.
Great. Thank you so much. So thank you so much. I think we are at time, Edwin. This was such good information, and thanks for being so available to us. We're lucky to have you out here.
Well, thank you. I'm happy to do it.
And to everybody on the call, as a follow-up, you'll receive a survey by email. Please take the time to complete the online survey. And to find out about upcoming webinars, please go ahead and join our listserv. You can visit our website to sign up. If you have any follow-up questions or if anything occurs to you after the call, please let me know. And put next month's webinar on your calendar. It's Wednesday, August 4th at noon. Stay tuned for more information on speakers and topics, but please join us then. And thank you so much again to Edwin. This has been wonderful. Thank you, everyone.